Good morning. Yeah, this is my second lecture for final years. Today I'm going to discuss about miscarriages. Right? Miscarriages. Actually, when we are discussing about the clinical cases of SEN or gynae, we are not discussing or we are not giving the cases with miscarriages. But that is as a differential diagnosis. That is maybe a very important part. But miscarriages in the essay questions, skill stations, then MCQs or single-based answer questions. That is, we are assessing in the in details about miscarriages. But basic knowledge and clinical assessment, clinical idea about miscarriages are very important. But the miscarriage is a spontaneous loss of pregnancy before their viability. That is, when we are taking as 100% pregnancies, 10 to 20% end up with this type of miscarriages. Again, that is other problem. That one, we have to pay the patient when we are diagnose that miscarriage, when a counseling, that percentage is very important. Something is positive thing for that patients, right? Giving that knowledge and idea. This is not only for her or their family. That is something 10-20% significant amount, significant number, right? That is when you are starting something counseling, that is important. Then, but anyway, it's not associated with the serious physical morbidity or mortality, but they are significant associated with the psychological impact to the mother and their family. Again, need to accurate diagnosis of the pregnancy failure. That is, most of the centers, those are managing in the obstetric department, they have their own guidelines, how to diagnose and what is the management plan. Again, after diagnose that miscarriage, then how we can give that message, breaking news. It should be a sensitive and professional manner. Again, as a final year student, when we are working as a house officer, we are assessing about the knowledge and your attitude about giving this message to the patient. That also some part of area we are assessing in your final year exams. What is the definition? It's a miscarriage of defined as a loss of pregnancy before 28 complete week of gestation. But that is 28 most of this part of the world. But ideally, when you are working in UK, sometime when you go to the NICE guideline, that is they are taking as 24 weeks, right? But it's okay. In somewhere 24, 28, we are taking as before 28 or 24, we can take as miscarriage. Then, even then weight is less than 500 gram. The embryo, that fetal parts less than 500 also we are taking as miscarriage. According to the POA, according to the weighting, both way we can discuss about the for diagnosis. Then there are two types of miscarriages: first trimester miscarriage and late miscarriage. That is after first trimester. That is from the 12 weeks of gestation. We are calling as late miscarriages. Then first trimester miscarriages. The etiology, again, very important part, first trimester and second trimester. First trimester, the most of the cases associated with the chromosomal abnormalities, right? When you're counseling, again, that was a very important part. Chromosomal miscarriages, even just one miscarriage, we are not trying to investigate. But according to definition, 3 or more miscarriages, right? Then 3 or more miscarriages, anyway, we have to assess the maternal and paternal chromosomal analysis, or even more than 3 miscarriages, that is 4 or more, then we have to take the fetal parts, products, and again assess the karyotyping. That is important to avoid that future, that type of pregnancies. And when especially for counseling, that is maybe an important part. But anyway, just one miscarriage. Anyway, we are not doing that one further, that type of details, chromosomal analysis. But you should know about 70-60% of first trimester miscarriages associated with the chromosomal abnormalities. Out of that, trisomies is the highest, somewhere more than 60. In between 67% is trisomies. Then, in addition to that, again, antiphospholipids syndrome, some drugs, tetragenic drugs, maternal medical condition, some chronic diseases like cardiac disease, heart disease, renal diseases can cause that type of first trimester miscarriages. Again, maternal uterine abnormalities like fibroids, bicoordinate uterus, that also can cause that type of miscarriage. That is, can cause first trimester and second trimester both. When you are thinking about second trimester miscarriages, you can see that infection and cervical weakness, they are the leading causes, not genetic causes. Then infections, chorioamnitis or maternal systemic infections can cause cervical weakness. Even my last lecture regarding that antenatal care, about value of ultrasound scan, first trimester ultrasound scan, we discuss about transvaginal scan and assess the cervical length. Then we discuss about cutoff value 2.5, less than 2.5, taking as cutoff value. Then those have second trimester miscarriage. Then next pregnancy, when they are next pregnancy, first trimester, again we can offer transvaginal scan and ask to a cervical length, because that may be a possible cause. Then most of the time, if it's diagnosed, then we can go to cervical cerclage somewhere 13-15 weeks. In addition to that, structural uterine abnormalities, just after procedure may be difficult. After 3 months, then we can offer again another transvaginal scan and assess uterine abnormalities. Again, thrombophilia problems also can cause. Genetic causes, what we discuss when 13, 18, 21 and monosomy X can cause genetic causes. That is, comparing the first trimester, that is only somewhere 20-50%, 15% can cause genetic causes in second trimester miscarriages. Again, this is how to confirm the diagnosis, the miscarriages. First, as a house officer, first you have to get the proper history, whether cycle is regular or irregular. If cycles is irregular and she's aware about her last menstrual period, then this period of amenorrhea is more than six weeks, we can offer transvaginal scan and we can diagnose the miscarriage. Then other thing is the other possible causes, that is, can be earlier, the first time is a per scan, then we can diagnose a viable pregnancy, but later it can be end up with a miscarriage, complete miscarriage, incomplete miscarriage, or inevitable miscarriage. Again, the patient having a irregular cycles, patient now aware about the last menstrual period, maybe she sought contraception or breastfeeding, or anyway even priming, irregular cycles may be due to polycystic ovaries. Then that type of situation, then we have serum beta HCG may be an important value to discuss about the further management. Then usually cutoff value we can take as 1000. Depend on the 1000 high, less than 1000 or more than 1000. There's a guideline to management. I'm not going to discuss, it's not necessary. But anyway, there's a value of taking again serum beta HCG for further diagnosis and management of the miscarriages also. Then clinical diagnosis. There are two ways of diagnosis: clinical diagnosis and ultrasound scan. But ultrasound scan now freely available. In the presence of that ultrasound scan, most of the centers is available, even base hospital, even some district hospital also it is available. Then we are not dependent on the only clinical diagnosis, right? Always clinical plus ultrasound scan. That's better. I mean, as a final year student, better go there. But you have some idea about when a patient presenting to the bleeding PV, what are the signs of what are the important signs and symptoms that's been in clinical diagnosis for miscarriages. Then history of vaginal bleeding. In addition to that, may plus or minus amenorrhea is not necessary. Amenorrhea, as I mentioned earlier, those who have irregular cycles, sometimes they are or patient not or breastfeeding, maybe patient not aware about the last menstrual period, or maybe there's no amenorrhea. It's not compulsory. But urine HCG, that's very simple. Then urine HCG should be positive. Then positive urine HCG, history of vaginal bleeding, plus or minus abdominal pain. Abdominal pain is again not an important factor. As example, if there's a miscarriage, then abdominal pain not associated with always with the miscarriages. And next step is, as a house officer, then after proper history, general examination, then you have to do a speculum examination. Then after speculum, that is, I'm discussing about the clinical diagnosis of the miscarriages. Then after history and examination, and with especially after speculum examination, what is the appearance of threatened miscarriage? Then threatened miscarriage, then when you are doing if I'm not usually we are not recommend do all the patient is pelvic assessment, but if you have done a pelvic assessment, uterine size is compatible with the period of amenorrhea, and cervical loss may be closed, right? And there's a mild, can be a fresh bleeding or sometimes brownish color bleeding, but most of the threatened miscarriage is associated with the red color bleeding. Then if you done ultrasound scan, according to definition of threatened miscarriage, there's a live pregnancy. Then inevitable pregnancy, if you have done a speculum examination, then uterine size may be normal, say almost same as a period of amenorrhea, but or cervical, according to the speculum examination, cervical loss is open and pregnancy is inside the cavity, but os is open. That means within few hours is going to miscarriage. Then incomplete miscarriage, the patient having with a history of some bleeding PV, and again patient complain about bleeding PV plus abdominal pain. Most of the incomplete abortion, they associate with the abdominal pain, bleeding, that means passage of clots. In a speculum examination, you can see the cervical os is open. Then when you are assessing the uterine size, can be the same or less than that. When complete miscarriage, what happened in the clinical picture when we are asking the patient history, she's with the history of significant vaginal bleeding with cramp-like pain. Now, at the time of admission, there are spontaneous resolution of bleeding, and cervical loss can be closed. Right? That is important. Or sometimes maybe some parts inside the vaginal passage we can notice, but os is closed. When we are doing a speculum bimanual examination, uterine size is almost normal size uterus. Miscarriage. Miscarriage, again, if you have done a bimanual examination, uterine size can be a less than normal size. Again, there's most of the pregnancy signs maybe disappear at that level, and speculum examination, os is remain closed. The amount of blood loss, bleeding, is not that significant. Small, maybe a spotting-like bleeding, or sometimes they come and complain about brownish color discharge or brownish color bleeding. There's no fresh bleeding, most of the miscarriage. Then again, if I'm repeating that one because that is important, most of the miscarriage clinical assessment, then pelvic assessment, uterus can be a normal size, or less than the period of amenorrhea. Then there's mild spotting-like bleeding, most of the time brownish color discharge. Then mild abdominal pain is not that significant compared with the incomplete miscarriages. There's a mild abdominal pain, or sometimes it's not necessarily or always that associated with the pain. Then the speculum examination remain closed. Again, miscarriage associated with the infection, that is sepsis, abortion. Sepsis, if you're suspecting some infection, Then there's the picture associated with vaginal discharges, bleeding, plus or minus fever, again abdominal pain and abdominal tenderness. Uh, uh, when bimanual examination, their significant tenderness can be associated because of that ongoing infection. These are the main important part for clinical assessment. Ultrasound, again, when we go to that ultrasound scan, that diagnosis of the ultrasound scan, that is very important. That is, as a final year student, you have to come and see what when somebody is doing, your consultant, your registrar, your senior registrar, when they are doing the scan, you have to come and see that. That is, need to familiar that how to diagnose ultrasound scan. That is very important. This one is showing that intrauterine pregnancy and with a gestational sac, but we can't see the fetal fall, only gestational sac. This may be a very early pregnancy. Usually fetal fall we can see after somewhere after 6 weeks, 6 weeks, in between 7 weeks, clearly we can see fetal fall. And again, fetal heartbeat, we can see complete of 7 weeks. Again, this another picture showing that one fetal fall and yolk sac. Presence of the yolk sac give idea about the actual intrauterine pregnancy. That's a very good sign. You can see gestational sac, intrauterine pregnancy, fetal fall, and yolk sac. Again, this one, this is the picture of the incomplete miscarriage. Then it was an intrauterine pregnancy. Then you can say some endometrial thickness. Usually endometrial thickness less than 1.5 centimeter. We are not doing anything. Most time we can counsel the mothers. If it's less than 1.5, we can put as a complete miscarriage. But in this here, there's some significant endometrial thickness is there. That is, we can put as incomplete miscarriage. Again, another gestation sac. Yeah, just seeing this one is irregular sac, right? It should be a miscarriage. Then you can see margins are not very clear. There's no intrauterine pregnancy. Or there's some intrauterine pregnancy, but it's not very clear. Margins are very, very irregular. It can be a miscarriage, but very difficult to give more details. We can't visualize that heartbeat. But only thing is I can say, just see this picture, sac is very irregular sac. Again, there's a other regular sac, and there's a fetal fall there. Then you can see the length of the full length of the fetal fall. This measurement is the crown trub length. Yeah, when we are seeing a diagnosis of threat miscarriage by ultrasound scan, then always intrauterine pregnancy sac, fetal fall, and cardiac activity we have to see. Then other example, what is most of the time, what is we have done, we have mistake in the most, sometimes in our board, so even our management in the board, just POA there, it may be not accurate always. Then that when we assess in the fetal fall is not accurate with that period of amenorrhea. But sometimes we can't see the cardiac activity. Patient coming with the bleeding PV, intrauterine pregnancy there, the fetal fall is there. If you can't see the cardiac activity, right, then sometimes we can reassure and we can discharge the patient and assess in 2 weeks time. Or in between, patient having a bleeding has to come and admit. Here, when we are discussing about fetal fall, in the absence of the cardiac activity, what is the length of the fetal fall, minimal length? It should be 6 millimeter, right? Is in the presence of the fetal fall and full length is 6 millimeter or more. In the absence of the cardiac activity, we can say miscarriage. In the fetal fall, less than 6 millimeter, if there's no cardiac activity, then we are no hurry to give that our definition. Then better counsel the patient and discharge the patient and reassess in 2 weeks time. If there's only gestational sac, the diameter of the sac is uh, 20 millimeter or 20 millimeter or more, in the absence of the fetal fall, we can put as a blighted ovum and embryonic pregnancy. But gestational sac, the diameter of the gestational sac less than 20 millimeter, there's no fetal fall, then if you have comment that one is miscarriage, that is wrong, right? The thing is that if the patient is stable, then counsel the patient and better repeat scan in 2 weeks time. Incomplete miscarriage, then already I have showed that one, some diagram of the incomplete miscarriage. Again, we can see heterogeneous tissue plus or minus sac destroying the midline endometrial echo. That echo that we have usually assess the thickness of the endometrial thickness. Then is more than 1.5, then we can put as an incomplete miscarriage. Then how to manage that one we can discuss in the later. Again, complete miscarriage, endometrial thickness is less than 15 millimeter. There's no evidence of retained products of conception. Then counsel the patient. Then we can offer about the pregnancy we can counsel about, and the further management. Then how to discharge we can discuss that part also later. This miscarriage, again, I'm coming to that point. That is important. As a final year student, most of the time they are assessing that part. Then fetal fall is more than 6 millimeter. There's no fetal heart activity. Then we can put as a miscarriage. Delayed miscarriage or blighted ovum, then gestational sac diameter is more than 20 millimeter. But in the absence of the fetal fall or yolk sac, then we can put as an embryonic pregnancy. Then what are the, when we are taking the history, what are the prediction of miscarriage? One is the maternal age. If the maternal age is more than 42, there's a 40% of chance the risk of miscarriage. The main reason is a chromosomal anomalies. In addition to that, in the previous history of miscarriages, again, patient is present with the bleeding PV, that type of causes possible, that also can import with prediction of the miscarriage. Psychological aspect, again, other important part. If patient having a miscarriage, then how are we going to be taking that news to that patient? Again, 50% of women after diagnosis of miscarriage, that can be end up with some significant psychological effect. But that is very important. She is in your ward. When you counsel the patient, that how to give that message is very, very important. Always when you are counseling the patient, then give something is positive thing. Positive thing is first, and after that you can break that news. As example, the young girl is coming at 25, at the age of 25, married up just after 6 years, six months, right? If you conceive and end up with a miscarriage, then you have to counsel about her age. She's young, and within short period, within 6 months, she conceived. That means we can assess. Obvious, there's no problem with the husband, partner, or her, the tubal problems and forming of eggs, because everything is now already assessed by that because of the pregnancy, because of some reason. Maybe most probably if they are miscarriage within first 12 weeks, maybe fetal problem. Like that, give something positive first, and after that, give that your diagnosis and discuss about management plan. Again, that the common mistake, what is we are doing in our board, right? When we are asking from the students, then when they are plan for next pregnancy, quite common questions they are asking that. Again, most of the time they are asking 3 months, 6 months, or sometimes even they are asking some even more than that. No, that is wrong. If the patient, most of their patients are young, there is no psychological aspect at that diagnosis at that level. Patient is healthy. There's no associated with the if there's no associated with some other undergoing medical problems like chronic diabetic, hypertension, or that type of thing. Because of we are asking to prevent pregnancy or temporarily avoid pregnancy till that part is complete control. Then we are doing something short-term contraception also. Otherwise, healthy patient, young age, especially first trimester miscarriage, not necessary to wait for significant period. what we can counsel to them, then they can plan a pregnancy when they are starting their next period, when they start their period and continue for another baby. And same time, at the time of discharge, and asked to maintain especially folic acid. Again, these are mainly important practical points. Then incident of miscarriages. Miscarriages, again, when a counseling, that is important. What is the percentage of miscarriages, especially 10 to 20% is maybe there. Clinical diagnosis, as I mentioned earlier, only clinical diagnosis is not reliable always. Then always we also can associate with the ultrasound scan findings. Altogether, we can finally come and discuss with the patient. Again, if the not very sure about maybe a very early pregnancy, then without doing our management, better repeat ultrasound scan and repeat, reassess the patient in 10 to 14 days, roughly in 2 weeks' time. Again, incomplete miscarriage diagnosed by ultrasound scan, mainly endometrial thickness of the endometrial cavity. Again, endometrial thickness is unreliable factor. It can be various reasons, or sometimes because of hormonal treatment, their thickness can be varied. Right. If a patient is coming with a bleeding PV to your unit, gynecological unit, as a house officer, what are the things first? First, we have to take the patient proper history, examination. Then history, when we are asking about when was the last menstrual period, always bleeding patient, we have to ask that one, but even not 100% accurate. Then at any young reproductive age, patient with bleeding PV, do a urine HCG. If urine HCG positive, always think about bleeding, that what we discussed, the possible miscarriages, and other one is ectopic pregnancy or HMOL. These are need to that idea in your always in your mind. Again, we have to assess the patient blood pressure, then pulse rate and respiratory rate, very important. If patient hemodynamically unstable, first manage that part and need to get the help from your seniors. And same time, you have to put a cannula, wide bore cannula, depend on. I mean, patient is hemodynamically unstable and take the blood, especially while you are taking the blood for cross match, at least 2 or more, depend on the severity, and full blood count and clotting profile. This is important. In addition to that, patient has to assess the temperature chart, especially can be a septic miscarriage, or especially that patient having miscarriage, hemodynamically unstable, can be associated with the underlying infection or septic abortion. Then assess the temperature is very important. Again, hemoglobin level, depend on hemoglobin, you can discuss about the further management. And after that, after managing that everything, then we need to get the proper medical assessment of the medical history and make sure that there are no other comorbidities. Again, need to admit, and depend on the situation, you can discuss with your seniors. How we are going to manage? Management options: expected management, medical, and surgical. Then all three we can discuss, right? Expected management. Expected management, 70% of the miscarriages we can manage with expected management. Then actually all three are almost same. There's no evidence of infection expected early. Some are really worried about expected management. Even patients are not happy because they are worried about risk of infection. But only main problem is it takes long period. Sometimes we can't, that's the main problem. We can't predict then how long it will take the complete of that management. That is the main problem, is expected management. Mainly success of the expected management depend on that type of miscarriages. As example, it is incomplete miscarriage. The success is very, very high, 80–90%, because of miscarriage. Osis, we already discussed, osis close, there's no bleeding, mild spotting-like bleeding. Then expected management, that will take long period. Again, process of vaginal bleeding, something is positive thing for success about the expected management. Like that, you can discuss patient when you are discussing about the options. That is important. Again, always when you are counseling the patient, discuss about the advantage and disadvantages with each procedure. The main advantage is there's no, it's necessary for any anesthesia, especially general anesthesia. There's no, again, invasive surgeries, because sometimes going to that surgery, they are surgery related, uterine perforation or cervical tears, because sometimes it's difficult to open the cervix. Again, even medical management, that side effects of the drugs, everything we have to discuss. These expected management, they are completely free of that type of problems. Again, feeling of control over situation. These are mainly advantages, yes, related with the expected management. But main disadvantages, as we discussed, can't predict what is the time, right? Other one is the bleeding can be heavy and painful, because time to time patients are really stressful, because what is the end, how long they have to wait. These are mainly problems. In addition to that even if you try that expected management, sometimes they end up with the surgical and medical management, because sometimes it's not complete. Again, medical expected management. Then before going to a medical management, other important, the expected management, if you diagnose threatened miscarriage, that is only option, but this is the expected management. Then we have to reassure the patient, counsel the patient. If first we have to assess the hemoglobin level, everything is normal. In the absence of bleeding, after confirm our diagnosis in the live fetus, we have to counsel the patient. Then what we can do, we can discharge patient, and again we have to assess in 2 weeks, do another scan. But in between, after discharge, if patient having significant bleeding, or patient have something, any other problem, especially bleeding, has to come immediately, and because we have to assess repeat scan. Then what is the place for progesterone? Most of the time in our wards, we are giving that treatment, progesterone, but according to the NICE guideline, still there's no evidence, any support for using that one. But when we are discussing about clinical cases, what you can say, because most of the time we are giving the progesterone available, can be given oral, even we can into the vagina, or even we can injection, as injection this is available. Maybe some effect, but still no evidence of giving that progesterone, but no harm. There's no any side effects of giving that. But when you are discussing about some clinical cases, that may be important part. Again, when we have discussed with the patient as well. Then after for even expected management, we are asking come to in the 2 weeks time. In between, patient having heavy bleeding, right, has to come early, because can be associated with, sometimes can be incomplete miscarriage, because sometimes incomplete miscarriage, again there are options, heavy bleeding, need to discuss with the patient. Again, we can offer expected management, or depend on the patient choice, can we end up with the medical or surgical management. When we are moving to the medical management, again, medical management, even I mentioned about 20% nowadays, almost 80% of our unit, our ward, we are managed with the medical management. Very rarely going to that surgical. Even we are trying 1 or 2 2 cycles, if not respond, then we are going to the surgical. Most of the time we are trying with the medical management. That is our Peradenia. Again, the main advantages are the treatments, drugs freely available, different regimens is available. Again, we can take as oral doses. Again, we can put in the vagina, right? Various drugs regimens are available. Again, medical management success rate mainly depend on the POA. If period of amenorrhea is less than 10 weeks, again success rate is high. Then prostaglandin, misoprostol, now very popular, right? Prostaglandin E1 is very popular. Drugs is available in our centers. Then if you are misoprostol, if you are using misoprostol, it's the incomplete miscarriage. What is there according to NICE guideline? What is the advice? 600 milligram this as a single dose. Is the miscarriage, they advise 800, that means 4 tablets as a single doses, right? That's also important. But even incomplete miscarriage, even sometimes we are putting a 400, 800, that means 4 tablets also. That's also, but ideally we can start with the 600 for incomplete miscarriages. Then other antiprogesterone actually still in our unit we use that part. We are using that one, especially those are coming at 20 weeks or 18 weeks, because we can't go direct surgical management. That type of patients, then usually we used to give mifepristone, antiprogesterone. After 48 hours, we try to give prostaglandin. But according to NICE guideline, they are not recommend antiprogesterone for management of the miscarriage. According to NICE guideline, even we are using that. That is, be careful when you are assessing your some MCQ. That according to NICE guide, they are not recommend antiprogesterone, that mifepristone, to manage the as a medical treatment for miscarriage. What is their advice? Misoprostol now it's available. We can use misoprostol for that medical management. Advantage of medical management, again, there's no general anesthesia. Again, surgery related, there's no risk. Again, compared to the complete miscarriage is more quicker. That is because most of 1 or 2 cycles we can complete. Disadvantage, again, pain and pain is the main problem in between, because of the at the time of passage, passing the particles, there's a significant pain may be there. Again, always counseling about that situation is very important. Again, duration of the bleeding, sometimes even can't predict. Then other thing is that, again, even we are trying that on medical management, maybe end up with the surgical management. These are mainly related with the problems with the medical management. Surgical is the most popular method, right? Most popular, but as I mentioned earlier, but even popular, still most of the our unit we are managed with the medical because of the unnecessary surgical exposure, patient because of risk. We are going to most of the time we are trying medical management. But when you are thinking about surgical, there are 2 options are there. One is the ERPC, evacuation, retained products of conception. Other one is a dilatation and evacuation. Oh yeah, the third one, suction evacuation, especially tight cervix, right? Then if it's not difficult with the open, then we can do suction evacuation. These are main options, especially if we are going to terminate, because in Sri Lanka, how legally we can, if the pregnancy is really affecting the mother's life, we can terminate the pregnancy. Then in that type of situation, most of the time we can use suction evacuation. Again, main advantage of surgical management is success rate is very, very high. That is 95 to 100%. Again, usually whatever the procedure, that one better do a repeat scan and see. Repeat scan and make sure everything is came out, because that is when we are counseling, that is important part of the management. When we are discussing about the surgical management, then what are the important instruments? However, what is the procedure? Yeah, when we are thinking, I'll discuss that one is later again. What is the type of anesthesia? Usually, most of the time we are doing general anesthesia, right? Under general anesthesia, we are doing that one. Then it's a simspecular, very important, just to visualize the cervix. That is metal catheter, just empty the bladder. Yeah, even before that, patient under anesthesia, you have to do a bimanual examination after they empty the bladder, right? First simspecular, then empty the bladder, then do a bimanual examination and get the idea about size of the uterus and whether anteverted or retroverted. And that is very important before your next step. Then this is green armitage. Prenormitage is we can use, but most of the time sponge holder we can use to assess the cervix because of especially valcellum tissue forceps is traumatic, right? It can this is prenormitage. That is the safety of that. You can identify that. Yeah, this is valcellum tissue forceps because it's really traumatic. Can see that one. Then better not to pregnant uterus. To hold the cervix, better not to use this one. That is when we are using a dilatation and curettage, we can use that one because there is not a problem. Then the next step is that put a sound and get the idea about the size of the uterus before your next step. Doing that one next procedure. Uterine, insert the uterine sound is very important. Hagas dilators depend on the if the incomplete miscarriage is oscis open, this is not necessary. I mean, it's miscarriage, oscis closed. If you want to dilate the cervix, then we need that Haga dilators. Usually, we are starting from the smallest one to large one, depend on that our requirement, we can use that one. Right? It's a main advantage is a blind procedure. The blind ends are blind, then there's a chance of damage. The uterine fundus is very low, but anyway, we are not going to that up to that level. Just to dilate the cervix, we can use this. Yeah, sponge holder, that is very important. We can use this one to just handle the anterior lip of the cervix. In addition to that, to remove the products, we can use that. Yeah, better not to use that curage during that pregnant uterus because it can damage the even there's chance of perforation. Not only that, unnecessary traumatic damage to the endometrium. Yeah, the results of that, if you are using that one too much damage, that one maybe end up with some adhesions in the later pregnancy. Even for conceive for next pregnancy can be affected. It's real most of the time when you are doing ERPC, we better avoid this part. Again, mode of anesthesia I have already discussed, but most of the time then we are using the general anesthesia. Then surgical management advantages is predictable, low risk of needing further treatment, reduced duration of bleeding. Again, these are main thing. But why when we are doing surgical management, just using a Hagas, better avoid that too much force to the cervix, right? Because when you are using that one, can damage and cervical trauma. Even if you are doing too much cervical damage, end up with the cervical incompetency, and next pregnancy can be end up with the preterm labor. That type of possibilities are there. Not only that, hemorrhage and uterine trauma, damage to the uterus, and even through that can damage the bowel as well. Be careful. It's a gentle procedure. We have to use that one. That's why important of the sound and get the bimanual assessment. You assess the uterine size and whether anteverted or retroverted. At the same time, use the sound and get the idea about the size of the uterine cavity. Using this knowledge, then we can minimize that surgery-related complications, especially traumatic procedures. Disadvantage already we discussed that one, damage and intrauterine adhesions. That's why I said that one better not to add curettage to the endometrium in the process of miscarriages. Again, these are mainly for practical points. Then risk of infection are similar in the all treatment options. Again, I have forgot that one. The patient having a previous history of infection, right? Patient is already having infection. Patient, the risk of infection or uncontrolled diabetic or vaginal smelly discharge, that type of patient better not go to the expected management because we have to correct that one as early as possible and we have to give antibiotics and correct. Most of the time, we are end up in the surgical management after giving antibiotics, or sometime then we can go to medical management as well, but expected management better avoid. And in other conditions, avoid the expected management. Those who have risk of heavy bleeding, as example, or some underlying bleeding problems, bleeding this history of risk of some, or their bleeding disorders. better not to go to expector management, or even the blood transfusion problem. Those are working in some centers, is there's no facilities for blood transfusion, or patient is somewhere far away, difficult to come to the center with the bleeding. That type of patients, it's better avoid expector management. Then we have to discuss about medical and surgical management. Yeah, other important. These are mainly discussed. I complete my management about miscarriages, expectant, medical, and surgical. In addition to that, these are also we have to think about. In addition to that, our management. Then anti-D. When the patient is diagnosed of miscarriage, even threatened miscarriage, even patient had significant pain, less than 12 weeks, patient during that uh, bleeding associated with the abdominal pain, they are recommended for giving rogam. In addition to that, in any after medical procedure, surgical procedure, we have to give rogam. Then even my antenatal lecture, I discuss about doses that is up to 20, from 22 to delivery during antenatal period. Then you have some idea. In addition to give, then if they diagnose ectopic pregnancy, we have to give rogam. Again, any early first trimester procedure like chorionic sampling, amniocentesis, then again we need that giving that rogam. Septic abortion. Septic abortions organisms, I'm not going to discuss about details. Then septic, then how their patient is present to us. Then important the clinical history about patients. Again, urine HCG should be positive. Patient may or may not bleed in PV, right? May associate with the vaginal bleeding. For patients, sometimes giving that something idea, we can get some idea from the when patient taking from the history about the septic abortion. Again, septic look, that is when your assessment, general assessment is very, very important. And pyrexia, again, temperature, maybe a significant fever, or sometimes it's not 100%, but even most of the patients having septic abortion, they are coming with the fever. Again, when we assess her tummy, in the lower abdomen, it's a tenderness. Bimanual examination revealed tender, or adnexial tenderness may be there. Again, Paul's blood stain discharges through the vagina. That's also important. If you notice that one, we have to take the high vaginal swabs and take the culture and ABSC, because that future, before starting antibiotics, that is important. And tenderness, vaginal examination. If vaginal examination is really difficult, do a rectal examination also may be important. Again, patients, when you're asking the patient, sometimes they are not pass urine from enough urine, that is oliguria. That type of suspected patient, we have to put the catheterize and assess the urine output. Then investigation. After proper history, after examination, then high vaginal swab, I mentioned that one is very important, and full blood count, urine full report and culture and ABSD, blood culture and blood for culture and ABSD. This is before starting your broad spectrum antibiotic. Otherwise, there's no effect. And same time, renal function test is also important, because they directly can affect if they're in the presence of the septic condition, it can affect the renal activity. Then renal function test is important, and protein profile again are the important factor, and CRP. This the UD level, your unit, they can do CRP. I didn't mention here, and renal function test I didn't mention here. That's also important investigation. And ultrasound scan, need immediate transvaginal scan, assess the endometrial thickness, uterine assessment, and whether adnexia, and assess the prefluids. Because sometimes can be a perforation and bleeding may be there. Then assess the prefluid also important. Treatment. Again, IV cannula, even sometimes if patient can be dehydrated because of the septic condition. Sometimes you have to do white bore cannula. Depending on the situation, you can decide. Again, IV fluid depend again on your assessment, blood pressure, pulse, you can get idea, and put a catheter and assess the urine output. So then you have to give a hydration, very important, immediate fluid replacement important, and we have to get down the investigation, especially blood count, hemoglobin level, and take the blood. Same time when you are putting the cannula, take the blood for cross match. Again, if depending on the hemoglobin level, we need blood transfusion. Again, IV antibiotics, and same time need to inform multidisciplinary approach, microbiologist, consult anesthetist, hematologist, or medical team, and including that gynecologist. Or it's a team management. So sometimes, depending on the severity, patient should be managed in the ICU or HDU. Then when to do if there are ultrasound scan, if we diagnose retained products, when to do a ERPC. First, we have to correct the patient's hydration, stabilize the patient, start IV antibiotics. After that, we can do ERPC. It's not immediately better not to do. First, we have to stabilize the patient, start antibiotics, and go to the ERPC depending on the findings. These are not really important. That is again complication, but you can, it's complete theory. Then you can read that one. What are the possible immediate complication of the septic abortion? Yeah, bacteremic shock, anuria, acute peritonitis. If that perforation of uterus already we discussed, because keeping in that mind, these are the possible complications when we are assessing. That is very important. Again, late complication, tubovarian abscess, again generalized septicemia, again finally maybe end up with the subfertility, because tubovarian abscess, again planning on next baby may be difficult to conceive, right? These are the possible late complications. Then again patient assessment, counseling also important. Then I would like to move that other important topic, recurrent miscarriages. Recurrent miscarriages, again, cases, it's not giving that it's undergraduate student, but it's mainly really good topic for postgraduate. But the OSCE stations or even sometimes theory paper, MCQs, we are assessing that knowledge about the recurrent miscarriages. But it's a WHO definition. It's a consecutive loss of 3 or more fetuses or weight less than 500 grams. That is recurrent miscarriage. Then when we are investigating, we have to give some idea about what are the underlying causes. Again, karyotyping from both parents, karyotype of fetal products. Usually karyotype of fetal products is 4 or more miscarriages they are recommended. And again, send maternal blood for lupus anticoagulant and anticardiolipin antibodies. Again, pelvic ultrasound scan to assess the uterine and ovarian abnormalities, especially uterine anomalies, because can be uterine fibroids, submucous fibroids, and bicornuate uterus, uterine anomalies we have to exclude. Again, mid-follicular FSH, LH level assessment important. Or mother is having symptoms, especially, then there are symptoms, we have to do fasting blood sugar and thyroid function test. Again, investigation for infection, cytomegalovirus, toxoplasmosis, hysteria. That type of infection also we have to exclude. These are mainly I want to discuss about miscarriages. Then I think you have some idea about the management of miscarriages. Better go to the then even my putting this one model, I try to that one. What are I got from the NICE guideline? You can go through that one also, and go to the past papers and see that one. What are the questions they ask about that miscarriages, and we do some MCQs, especially miscarriages. There are a lot of MCQs there, and again how to counsel that after diagnosis that miscarriages. Then how we are going to take in that news, counseling, and management option. This is important. Then thank you very much. Yeah. Yeah, I'll put that one for mortal.